Sherif, for this invitation, giving me this opportunity, even with you are now in the EVAR era, so that no any discussion for this particular topic. Everybody in the audience know that the trends, especially in U.S., about the AAA treatment is more prone to have EVAR than to perform open repair. It is also the case in Europe, where in the 2015, 65% of the cases were fixed by EVAR and only 35% by open repair through around Europe. After the NICE, we discussed about that so often here in this podium and also in another congresses. In summary, the NICE draft guideline told us that no offer EVAR in surgical repair is suitable, or if they are unfit for surgery. So it seems to be that EVAR is in danger to be disappear, or at least to have more consideration about the EVAR indications. So what should we do thereafter the NICE going to appear? Because it still is a draft, and we are waiting for so much for this particular document. But you need to recognize and overcome the EVAR limitations. There are some limitations for sure. We need to improve the endograft design and apply it when approved, and collect more data and monitoring them, and adherence to IFUs, and satisfy all the expectations from the patient, from the doctor point of view, as well as from the administration point of view. And don't forget, open repair is still available, and also is important to train our young patients about the open repair that is more often forbidden or forgotten in most part of the Occidental countries. So about the outcomes related to the volume, everybody knows that the volume is related to NICE outcomes. This is a paper coming from the UK that recognized that for surgeon we need at least 13 repair per annum in order to have good outcomes in terms of open repair. And by center you need to have 45 AAA repair intact AAA repair per annum, and 15 rupture aneurysm repair per annum in a center in order to get good outcomes. That is quite important to recognize that is not the figure in most part of the even for the training or teaching hospitals. What about the solutions for that? One solution, simple one, is centralization, that is performed also in UK. And this you can see here the figure in the United Kingdom in this particular column. This is the mortality, about 8% mortality for intact AAA repair. In 2007, it's quite high mortality, and that put the alarm in the UK country in order to perform something in order in consistency with the recognition of the vascular surgery as independent specialization in 2012. That is, the centralization represents to have hub hospitals and other non-hub hospitals in UK. There are some centers that is forbidden to perform the AAA repair, and others are centralized in order to get more volume and better results. That is also collected in the previous ESBS guidelines that we need to have. This is for sure is an arbitrary number, 50 elective cases, even either endo or open repair. That is a level 2C with a recommendation B in order to get good outcomes. And also the most recent guidelines from the European Society, they recognize that only with 30 repairs could be enough in order to get good outcomes in terms of good outcomes for AAA repair. We got in our experience in our country, Catalonia is a region of Spain with 8 million population, and we demonstrated what has happened with the centralization. So we select all the centers with more than 30 cases per year, and that is the figure before the centralization. 22 centers in my country represents or were allowed to perform AAA surgery, open or endo. At the end of the centralization, only 10, and for thoracic, only 5 centers are allowed to perform this kind of surgery. So that is the trend in intact aneurysms and rupture aneurysms. You can see here there are a lot of there are not any difference before and after centralization. And after centralization, you can see here still there are some increase on of EVAR repair and decrease even the open repair after centralization in 2015. Also very important to try to understand that the mortality trend improved a lot after centralization. As you can see here for open repair, especially for open repair, as you compare with endovascular, even increased a little bit more after centralization because we face more unfit patients and we face more complex patients for this particular repair, endo repair. That is the trial for in terms of intact aneurysm, we decrease the mortality a lot of centralization. For rupture, we maintain the same kind of mortality. So that is in summary, before and after centralization, all AAA mortality decrease after centralization. And for intact AAA, we started for 4.1% and we decreased about 2%. And also for rupture, we started 52% mortality, and after centralization, 37% mortality. That all of them were statistically significant. Another solution, because centralization is quite sensitive, is to play with a simulation, but you know that the simulation is just an approximation of the reality, and the reality is a little bit far away from the simulation. There are some different kind of programs in different countries, especially in US and also in Europe. Another important strategy is to become partnership or to have some agreements with another high centers. We have now, in my experience, a partnership with the Belgrade Center, it's a general hospital in Belgrade, with David is a professor, and Conquer is my fellowship. That is now is the chief of the open surgery and endovascular surgery for AAA. So we send our joint vascular surgeon to this center in Belgrade in order to get more confidence about open repair. So in summary, open surgery remains necessary. Training in open surgery is a global issue. It's not just for our own country, it's a global issue. Centralization, simulation programs, and collaboration with other institutions is key to maintain training opportunities to our young vascular surgeons. Thank you very much for your attention and opportunity.